Audio Jungle.
गुड मॉर्निंग गाइस, हैप्पी वीकेंड, हैप्पी सैटरडे। मैं अकेला ही चला था जानिबे मंजिल मगर, मैं अकेला ही चला था जानिबे मंजिल मगर, लोग साथ आते गए और कारवां बढ़ता गया. This is a share of Majroo Sultanpuri ji, which means कि when I started, I was all alone. Slowly, people joined in and we became a family. So, hellos to the Dental Reach family, all the viewers who are seeing this, all the students who are, all the clinicians who have played an important part, being here. So, I am Dr. Pallavi Mahajan, an endodontist, a writer, spoken word performer, your host and host for Scientific Sessions DRDCA 2020. And today is the last day of sessions, and the conference ends tomorrow with awards night. So, guys, it's been one hell of a journey. We started on 1st of November. We had 40 speakers on board. I remember, shouting like, "We have 40 speakers. Stay tuned, stay tuned." And now we have last 4 speakers are going on board with us today. So we have 2 sessions, one in the morning, one in the evening. For those, I don't think that there are any new viewers, but if you are, you are watching basically Dental Reach Digital Conference and Awards 2020 International. And we conducted a scientific session the month. We conducted it. It started on 1st November. It ends today. The scientific session ends today. And we have had 40 speakers. Most of the speakers, their sessions are there on YouTube, and Facebook DRDCA page, also on the app. For those who have joined us earlier, they know the importance of the app. It's the event. The app is called Eventi, and app is important to register yourself for the event in order to, if you need the certificate and those 40 CD points, you need to do that. Also, last time I'm announcing this, second last time, I'll announce once more. So, last time I'm announcing about Novolace laser therapy machine. This was a lucky draw contest, and the entries we are stopping at midnight today. So all the entries should come to us by midnight today, and awards will be the winner will be announced tomorrow 4 p.m. IST, Indian Standard Time. So without wasting much time, let me tell you about the sessions that we have today. We have one morning session, one evening session. 2 speakers are joining us in the morning, 2 in the evening. The first speaker that we have today, Dr. R.L. Halili Castillo. She's an aesthetic dentist who's joining us from Australia. Dr. Castillo obtained her degree in Doctor of Dental Medicine at the University of the East Manila, Philippines. She has been the clinical director of the Halili Dental Center and has acquired extensive clinical experience, which honed her clinical skills and provided comprehensive range of dental sciences to her patients. She has also practiced at the Health Promotion Board School Dental Services of Singapore, giving emphasis on oral healthcare programs for school children. She is an international lecturer with participation in numerous congress, hands-on, and online courses. She's involved in training and education programs specialized in fiber technology, aesthetic, and restorative dentistry across the region. She is a key opinion leader at GC Australasia. Dr. Castillo is going to speak about a topic that we have discussed prior, but she is going to bring her own side of, her experience with, I will say, fiber reinforced composite. The topic is a quick guide bridging the gap in minimal invasive way. And through this lecture, we are going to learn the tips and tricks to assist in ensuring successful treatment outcomes, the clinical information which is useful in case selection and treatment planning, also simple techniques that can be used uh, with e-glass fibers, reinforced composite that is synergistic with a range of aesthetic and high strength composites. So without further ado, and also just one info that all the questions, keep posting them in the comment section on YouTube, on Facebook, wherever you are seeing us, and the questions will be taken post this session. Without further ado, I welcome Dr. Castillo with us on screen now.
Thank
A
you.
very good morning to you, ma'am.
Yeah, thank you so much. Good morning, everyone. It's such a privilege to be here with you today. I am honored to be a part of this prestigious event, and really thank you to all the organizers, Dr. Nupur, Dr. Roxanne, and of course Dr. Palavi. Thank you for that very nice introduction. I am really happy to share with you some insights and clinical tips and tricks that hopefully will be useful in your daily practice. So today's topic is about the fiber reinforced composites and how we can utilize and maximize this type of restorative material in addressing different clinical scenarios in the minimally invasive and biomimetic way. So why is dentistry so important? So let me just play this very short video. All right. The smile is the very first thing we always notice on a person's face, and it makes or breaks a person's look. So it is important that that it is an important part of the face that so many people are very conscious about, and they really want to make sure that it looks good. Their smile is really good. So in this clinical situation, what are the treatment options? So again, from the perspective of the patient, maybe in his head he was thinking, oh, I should have opted for something fixed there so that I wouldn't have to go through that problem or that, accident. And again, from the perspective of the dentist, what could have I done to prevent this from happening? So, there are things that we always tell our patients. We suggest ideal treatment options, but then again, sometimes they don't go for it. Like if you have suggested, let's say, in an ideal world, you would like that to be an implant, but then patients won't go for it. So what other treatment options were possible that you can give to your patient that is cost effective, aesthetic, and of course fixed? So, modern restorative dentistry should be non invasive, adhesive, and aesthetic. So, less is best. Minimally invasive dentistry is applied as much as possible in addressing clinical situations presented in our practice. So, gone are the days where extensive tooth preparation or extension for prevention are being done in the mouth. So, because right now there is a systematic respect for the original tooth tissue. And the concept really aims to promote tissue preservation, or preferably by preventing disease from occurring and, of course, intercepting its progress, but also not removing and just replacing with as little tissue loss as possible. So, I'll be sharing with you a short video clip of my very first fiber reinforced bridge case, and then we shall delve deeper into the materials required as well as the techniques. along the way, I've learned as dentists, we learn and improve as we do things and as we do more of this type of cases. So later on, I'll be sharing with you those tips and tricks. And, I would always suggest that you choose an ideal first case in order for you to do and apply those steps that will help you achieve really great results in the end, such as this. Okay. All right. So that was my very first case, a very young patient, and of course, I need to address the situation in a very minimally invasive way. And this is something that I would always approach each situation with. It's really thinking about your patients like family. Is it something that I'm going to be doing for my family? Is this treatment something that I'd like to be done on me? So really important that you gain your patient's trust and you do what's best for the patient's interest. And of course, at the end of the day, whenever you have happy patients, you too will definitely be happy. So this is my daughter. Yeah, so she would like to become a dentist just like me. So that's really nice. So all right. So e-glass fibers. What did I use to come up with that fiber reinforced composite? So fibrous materials act to reinforce a matrix material by transferring the stress under the applied load from the weaker resin matrix to the much stronger fiber. So it is a structure that is made up of fibers and the composites, a synergy between those two, making it a strong material enough to be used in a number of different indications. So, in minimally invasive dentistry, the treatment methods should always fit into the patient's stages. So, stages of life. So, it's possible that with Eversix NB, just like what I did earlier, um, you're able to not rule out the other treatment solutions at a later stage or later date. So, whenever the patient is ready, so it enables you to prepare and something reversible minimally invasive solution where healthy tooth structure can be saved for as long as it's clinically possible. Because again, you just have to remember once the tooth structure is removed, it does not grow back. So you have to be very careful with how much tooth structure are you are actually removing unnecessarily. So fiber reinforced composites are not just used in dentistry; they're practically being used in all other applications, such as this, in this high tech applications. So really useful in dentistry because again, it is believed to really help, in our as a good armamentarium in our restorative work. So fiber reinforced composites in dentistry, there are a number of different types of fibers that we can find being used in dentistry. And as I have mentioned earlier, we Everstick range would have the e-glass fiber here. If you are familiar with Rebond or Construct and all that, they are polyethylene fibers. Everstick fibers really are surrounded by resin network as part of the manufacturing process. So it's really pre-impregnated with resin, so this ensures optimum performance, strength, and bonding compared to, let's say, a polyethylene fiber, which is practically a dry fiber. It has no resin penetration and can be incredibly difficult to wet evenly with resin. So you really need to soak it and make sure that the resin actually penetrates the fiber. So it's a little bit challenging to do that. Also, the thing with dry fibers, they are, they once they get exposed in the mouth, they tend to absorb more water or and attract more plaque and staining. So that's really the disadvantage. The good thing about Everstick fibers, they are pre-impregnated with resin, so it's easy to manipulate. It bonds very well. You can use your normal scissors to cut the fiber. Again, it can spread thinly, so it's really more for the comfort of the patient. So if it's able to spread out on the tooth structure evenly, then it's easier and more. It's better for the patient to get used to it. Again, it also contains, the chemistry of this e-glass fibers contains PMMA and composite. And so that's really compatible with not only composite, but also with acrylic resin. So in conclusion, what we say is that glass fibers are either, you can have, or fibers can either be pre-impregnated with resin or non-resin impregnated. But again, if you are able to get something that's already, pre-impregnated with resin, it's easier to handle those materials, it's easier to bond to those materials, and of course, in the end, you have better results. This is Professor Pekka Valitu. He is the inventor of the Everstick fibers. So he's being funded by the Finland government to do some research, and a lot of these researches he's done. And really, I've met him when I went there to in Finland, and He's still doing those research, and right now he's doing looking at fibers being used for implant or even prosthetic work. Okay, facial prosthesis. Yeah. So he's still doing all those researches. So this fibers, e-glass fibers, the Everstick range. This is really composed of a very very good structure called the IPN, or the interpenetrating polymer network. Because we understand that proper bonding between the fibers and the composite is really essential in order for you to have successful treatment for the patient. So this IPN, which is uniquely patented for this Everstick fibers, they are really clinically, leads to very good bonding, enabling reliable surface retained applications such as what I did. And again, you have better handling as well. So the unique IPN structure features ensures both micromechanical and chemical bonding of the Everstick fibers with composites. So again, the combination and the synergy of those composite and the fibers really make it a really strong structure. So the bond strength is based on the ability of the polymer matrix to partially dissolve the resin and be able to reintroduce um, composites into the fiber. So this actually IPN allows you to do, indirectly or laboratory made fibers, or you can do it at chair side, not just, directly like what I did. So I will be explaining with you uh, how this works as we go along. So the Everstick CNB is the thickest of all the range. Okay, so what we have there is about 4,000 fibers, and with a diameter of 1.5 millimeters. So the use of this fiber reinforced bridges offers a unique treatment method for, let's say, replacing missing teeth. So whether in one or two, just about two visits, you'll be able to replace that missing tooth. So with Everstick CNB, you can prepare composite bridges and reinforce teeth as well. And of course, as we understand, it's like a Maryland bridge, but the structure is made up of fibers. And we understand that the rigidity of metal framework can be really detrimental in terms of bonding. So that's the reason why a lot of our Maryland bridges with metal framework really fail. So with this fiber reinforced bridges, it's not as rigid as the metal, so it allows that physiologic movement of the teeth. So if you select this type of material or this type of framework, you have lower rigidity, and of course the stress is diminished or decreased. So it actually has better bond and and a resistance to stresses. So again, bonding is really crucial. So like I said, if you're using a metal framework, it's harder to bond it onto the tooth structure, especially if it's surface retained. But whereas when you're using this type of materials, which is very compatible with composite and bonding, you're able to effectively bond um, the framework or the bridge if on the tooth. And of course, with this treatment option or treatment approach, you're able to reduce biological cost for your patients. So again, you're able to offer something cost effective and minimally invasive. Where else can you use this type of treatment? Geriatric patients, of course. Um, we understand that there's an aging population, and this poses dental challenges for dental health professionals like us. So we are now faced with elderly who are partially dentate, and it makes it a little bit more challenging to manage requirements by these patients. And clinicians need to be aware of possible treatment options available for our elderly patients. So we need to be equipped to meet the dual challenges of treating and preventing the disease in a group which is usually hard to reach and hard to manage. let's think about, I've mentioned that, we're now seeing older patients with which who are partially dentate. Gone are the days we see all of them with complete dentures. So now they're partially dentate. And how do we actually help them in terms of being able to chew well, or being able to use the remaining set of teeth um in a maximum capacity. So how do we help them? So fact is, poor quality nutrition was reported mainly due to missing natural teeth. There's prevalence, as I've mentioned, of edentulousness declining. Okay, so they're more partially dentate patients. Clinicians are faced with treating number of partially dentate patients, and of course, we need to help them. We need to make sure that we are able to replace those missing teeth in order for them to be able to eat well. So, what other treatment options are available? I'm not saying this is the only solution, but this is something that you can think about, and this is something that you can actually apply for your patients. So, SDA, or the shortened dental arch concept, is really aiming to provide patients with functional dentition of 10 occluding pairs of teeth, and or contacts, which, without the need for removable partial dentures. So this mainly is preserving the anterior teeth. So normally it's the premolar to premolar occluding together. So patients were restored to a shortened arch of 10, occluding pairs of natural teeth and replacement teeth using resin bonded bridge work, or the fiber reinforced bridges. And so, of course, we they had to do the standardized protocol and so on. So they do the surface area bonding to the tooth, the remaining tooth structure, and in ensuring that this will be something fixed for the patient to maintain. So the clinical studies show that there was an improvement in the nutritional status of this partially dentate elderly. So it helped them being able to chew better, and without, with older patients, it's harder for them to actually adjust to partial dentures, right? So sometimes it's just, the way to go is really do something fixed for them. So I remember I had a patient before, oh, came back to me like, I think more than 10 times to just adjust the denture. And because she's just having a hard time adjusting with the removable partial dentures. And that's really, I mean, for us clinicians, it's really very tough. So what if we can actually do something else for the patient? So these are all possibilities and options. Of course, pediatric dentistry, as I've shown you in my first case, I would rather do something like this for my younger patients. And of course, you definitely would be confronted with congenitally missing teeth on young patients, or tooth trauma, their two front teeth falling off, and so on. And again, missing tooth due to caries. So a lot of studies have shown that, some people, some kids, if they don't go for orthodontic treatment, they sort of have get into accidents, and they get injuries and so on. What can you do to actually help those trauma patients? Or let's say if you have patients who have congenitally missing teeth. So this is definitely something that you can do, something very aesthetic that you can offer your patients. This really provides an ideal solution for fabricating high-end aesthetic bridge work. So these fiber reinforced bridges are very reliable and very aesthetic to replace, missing teeth, such as like in this situation. So again, the reversibility of this option of treatment option is really very ideal, because again, you have, it can be like a transitional bridge, or before any other more definitive treatment option will be done for the patient. So of course, like I mentioned, in urgent cases, trauma cases, this is something that you can do immediately for your patient, an immediate solution for your patients. Okay. Is it strong enough? Yeah, I mean, according to clinical studies, they've tested the strength of these fibers, and as you can see here, Everstick fibers really performs very well. The flexural properties are really, really good. Again, because of the technology, the IPN technology, it just makes the material a really strong structure that can withstand occlusal forces and so on. Okay. So the biting forces, as mentioned earlier, and the stress effect to bridges, normally you have about 900 newtons for the molar region. Average chewing of a person is about 100 to 300. So like I said, it can really withstand occlusal forces, and whenever you're chewing, so you're spreading out, the amount of force, so it really can last there. It can really maintain its integrity for a long period of time. So in this clinical situation, you can definitely come up with the solution that is fixed. Again, you just need to bond it onto the surface. It's again just making sure that you're choosing the right patient and choosing the right case. You need to make sure you isolate very well. You have to spread out the fibers when you're bonding it, making sure that the surface area is covered properly, um, and of course, explaining to your patients the importance of maintaining it. Again, without the patient really looking after her teeth, this type of treatments will not be successful. So make sure that you explain this is a bridge. They need to make sure that they look after the interdental spaces. They have to clean it regularly. And as you can see here at the last image here, this is after 10 years. So it's really something that the patient can um, really maintain, as long as the patient understands the repercussions if they don't look after bridges. So it is a bridge, so they need to make sure, or you need to ensure and explain to your patients that this needs to be maintained very well. um Survival rates, we can really say that this is a minimally invasive option. And of course, um you have to always consider whether you're gonna have to in do some preparations on your healthy enamel or dentin during the preparation phase. Again, we try our best to not be destructive to the tooth structure, so we want to be able to come up with a cost-effective way to restore missing teeth, just like this. But what about if you like to do it indirectly? So meaning you have a model and you do it outside of the patient's mouth, and it's done um, on the model. So definitely you can, because of the IPN structure. So because of the IPN structure there, it means you're still able to reintroduce fresh composite, and you are able to bond effectively onto the tooth structure. I'm going to explain with you. I'm going to explain to with you the how this mechanism actually works. So I'll just show you an example of a case where this is a two pontic bridge. So again, if you have two pontics, you will need four teeth to support it. Okay. So fortunately, unfortunately, this is really for your case selection. As you can see, this is a case by Dr. Anthony Mack. You can see that the patient has, cavities and caries on the palatal area. So in that case, you're able to replace those old restorations, and you can under contour it. So if you under contour, then you'll have space for your bridge, so to bond on the palatal area. So it's not going to interfere in the bite of the patient. So you have your wax up ready. You use your silicone key. You can use Flex-Seed or Exaflex. They're very good materials. And then you use your Everstick fibers and your composite along with it. So I would normally use Genial Universal Flow or Genial Universal Injectable. And then with building up your Pontic, you can use your Genial Anterior. So you can definitely perform very good aesthetic work. You can do your anatomies and so on with your multi-shade layering technique, in order for you to have a natural looking tooth. So this is what you can get thereafter. So really good. Your patients will be happy knowing that it's something fixed and very aesthetic. It's bonded on their teeth. All right. You can do it indirectly, as I've mentioned. So this is a case, for example, of a periodontal patient, where you have to really extract the tooth, and you need to make sure that you're able to replace it, because it's an anterior case. So what you will then need to do is, of course, make sure that these wings here are reactivated. So that's where you're going to be bonding your composite, and then put it into your patient's mouth. So the good thing about the fibers is really in this particular case, the main advantages is really um, saving the intact enamel and dentine of the adjacent teeth. So you're not preparing anything, you're just bonding to it. So it's really less destructive in that sense. And it also takes away the biggest stress, in the bonding areas, because you're able to maximize, the bridge that you've created. And it's not rigid, like I mentioned. It's less rigid than let's say a metal framework. So really works for your patients. So again, with the IPN, or interpenetrating polymer network, it really means clinically you're able to redissolve the surface, the fiber wings, let's say, and so you can bond the, the the bridge effectively onto the tooth structure. All right. How does it work? So what you will need is a stick resin. The stick resin is a light cure single component enamel adhesive. It's a pure adhesive material based on methacrylate. And again, it is used mainly to wet the fibers and reactivate the surface of the fibers. It's because it is a pure adhesive. You can actually use it as a wetting agent for your brushes. If you like to use brushes for your composites, you can use this as a dipping resin, because again, it is unfilled, so you can use it for that purpose. It does not contain any fillers, self-etching monomers, or solvents. So um, universal bonding agents that you're using right now definitely cannot be used for this purpose. So only pure adhesives like stick resin. So only Everstick has this, both thermoset and thermoplastic characteristics. So the thing is that it helps in the reinforcing of the material. They have the same unique structure, and they are individually salinized, the fiber bundles. So that means the linear chains, the cross-link polymer networks formed a hard structure, but it also has that elastic structures that actually creates that very good fracture toughness in the material itself. Okay. Adhesion is really important. So again, light cured structures can be rebonded and repaired. So again, if there's anything that, chipping of the veneering composite on your fibers, definitely you can use the stick resin applied on those fibers, and you can reactivate the surface, forming micromechanical bonds and reintroducing fresh composite into the structure. So you can definitely be sure that you have sufficient bonding with your fibers. So what you will need is a small amount of the stick resin placed, on the wings or the fibers. It needs to reactivate for at least 5 minutes, and then you can introduce and bond and use composite to cement your structure. So, for example, in this case where you fit the bond, you fit your bridges and check whether it is fitting very well. You prepare your bridge. So you apply your stick resin on the wings where the fibers are present. You leave it for at least 5 minutes. On the other hand, while waiting, you then prepare the teeth that you need to bond, or where you're going to be bonding them. You clean the surface very well. Of course, you need to etch. Again, if you're bonding on your enamel, so make sure you etch it. You apply your bonding agents such as G Premio Bond, a universal bonding agent, and of course, you use your injectable composites such as Genial Universal Injectable, and then you place it into the mouth and sit it right there and light cure. So in this case, you'll be able to have, a strong resin bonded bridge there. So again, clinical survival rates of these bridges are really good. So it can last up to 7.5 years. Again, it's like a normal composite. You can, if your patient asks, you don't guarantee anything. Again, a lot of factors need to be considered, and you understand that, not all of our restorative work can last for a long time. But if it does, um, then it's really a good one for your patients. So, but according to studies, it can really last a long time, at least for 7.5 years. And I've shown you a case where it lasted for 10 years. So, but typical composite, 5 years. So, more than that, it will be really good. Clinical studies also show that, the IPN structure actually really create that stronger adhesion for indirect restorations. And of course, you can do repairs thereafter. So you can definitely apply your stick resin on the fiber and reintroduce composite into that area. So what about it for posterior? So again, it is essential that you understand how it works. So there are bridge designs that can be maybe again this can be researched. You can check the website, I guess, and then if you have inlay retained bridges like this is what you can do. So if you have old restorations, you can definitely keep the fibers within those cavities, and to reduce torsional stress, you can have like a wing or a fiber running across on the buccal surface. Okay, so you measure your fiber. The more fibers you have, the stronger your bridge becomes. So especially for posterior region, you need at least two long fibers and a short fiber to reinforce your pontic. Okay, so in this case, um, you need at least two long fibers to be used for this purpose. So again, you prepare the teeth, remove all caries, remove all old restorations, and clean the surface where you're going to be bonding. Apply your bonding agent, etch it, and apply your bonding agent thereafter. Um, it's really composite, so you'll be doing the same um, protocol in terms of adhesion and bonding. Okay, um, you need to apply your bonding agent thereafter, and you thin it. Okay, in this case I would definitely recommend G Premium Bond for that purpose. And then you light cure it. Okay, you have to make sure you thin air dry for maximum 5 seconds, and then you light cure it for 10 seconds, and then you can use your injectable composite as sort of like the glue within your restoration. You start building it up slowly. So then you place your fiber, one fiber at a time. You can use this stick stepper instrument so you can protect, the other side. The other end is it is a flat instrument where it's really wide, and you can definitely protect the other side. So if you can do it slowly, you can do so with this instrument. And then you apply the injectable again, and you are able to put the second fiber on top. So that this just makes it uh, the structure even stronger. So there are suggested designs for this. So maybe you can ask your you can research and go to the website to check it out. All right. So again, with the transverse fiber or the short fiber, you can use that to increase or reinforce the pontic that you're going to be building up with your composite uh, restoration there. All right. So make sure that you cover the fiber entirely, so you don't let the fiber get exposed. So you try your best to cover everything and build up composite all around your fiber. Okay, so this is what you can achieve with this technique. Make sure also, especially for posterior, I didn't use it in the anterior because it's easier for me to isolate. But for posterior, I think it's a critical step. You need to make sure that you isolate well. You have your rubber dam on so that you're able to isolate, and you don't uh, you don't have those saliva contamination. All right. Definitely for posteriors, I would rather go for this type of doing things. So it's really indirectly made fiber reinforced bridge. This is a case by Professor Ian Myers, wherein this is an inlay retained case as well, where there's old restorations, and what you can do is really do it chair side, so the patient can wait there. This is actually an old man's or an old dentist a dentist CEREC, a cheap CEREC, or yeah, something like that they call it. Because you can still do it share side, patients waiting next to you, but you have your dye silicone material, and because this sets quickly, so this is like by Parkel Mark II, Mach 2. And you can have this prepared, and so you can build up your pontic and your bridge right on this model. So if you don't have, I mean, if you can use this type of material, this is really good. Silicone material instead of your stone models. It's easy, fast, and you can do it in single sitting for your patients. So this is what you can achieve in this situation. And again, you need to reactivate the surface. So this is where you need to make sure that you apply your stick resin on the wings. So this is because you want to reactivate the IPN so that you can reintroduce, because again, you've light cured this. So you need to reintroduce fresh composite to bond it into the cavities. In that way, you're able to effectively do that step. Okay. And then you fit it inside, do your restoration as normal. And this is what you can achieve in that clinical approach. Okay. So other Everstick range, just quickly go through with you. There's also the Everstick Perio. It is half the size of that of the CNB. Again, this is really meant for periodontal splinting. And of course, as I have mentioned earlier, um, with the e-glass fibers, you can see here, it's really not attracting a lot of bacteria and staining and plaque. So not comparing it with the polyethylene fiber, where it's really a big problem, because yeah, once it gets exposed in the mouth, it just attracts all these issues, and it's really not ideal. You can use this or Everstick Ortho for fixed orthodontic retention. So this is even thinner. Again, this is in replacement of your, let's say, metal um, retainer. So this is really something that it's something fixed. It's aesthetic. It's not metal, so patients more comfortable and smoother. So that's an option. For those of you who are still doing post, I know some dentists, they don't put any post anymore, but there's also this Everstick post where it's customized according to the root canal of the patient. It's not prefabricated, so you don't need those special burrs to just prepare your canals to accommodate the post. So this is really more minimally invasive. You're not removing unnecessarily the tooth structure. So it's just a better way of doing things. Again, I've told you I use it with these fibers. I use it with injectable composites. So last time I used Genial Universal Flow. Now I use the Genial Universal Injectable. It is a really, really strong material. Lets me inject easily. I can contour, I can shape. It's not slumping. Again, it has a full strength capacity, and of course, beautiful aesthetics and really good polishability. So this is really a revolutionary material where it just changes the way you do things. So again, with the technology that's inside, it has ultrafine filler technology that are all fully silane coated. So each filler particles are fully silane coated and uniformly dispersed in the matrix. That's why this material is really a strong material. It's comparable with the rest other paste composites. So this is really something that you can utilize everywhere. So Genial Universal Injectable, they're really great material. So you can use it for all cavity classifications. You can easily use it for fissure sealing as well. Again, as a liner, or if you needing to repair, indirect restorations, and of course using it with Everstick fibers. For the Pontic, I like to use this genial interior. Why? Because it just makes it predictable for me to get really nice results. Multi-shade layering technique. I use an enamel shade, an opaque layer dentine, and a standard shade dentine. So in that way, you're able to achieve um, the right balance of translucency and opacity. It just makes the restoration look really natural. Along with that, I also use the bonding agent, G Premio Bond, a universal bonding agent where you can do all etching modes. You can do selective etching, and total etch or self etch. So um, it has the functional monomers format MDP and MDTP. So you can also use it for repairs of zirconia, precious non-precious metals, and so on. So it's really very easy to use, and it's really giving you that good immediate chemical adhesion with the tooth structure. So that's really something that I like about this material. You can very easily do the step-by-step bonding procedure. Um, Again, selective etch, total etch, or self etch. But I would preferably do selective etching, etching only the enamel, and self etch for the dentine. Apply the G Premio Bond, dry that with maximum air pressure for 5 seconds, and light cure that for 10 seconds. Of course, wax ups are very important. Why? Because it just gives you the power of complete control, I would should say. So from the start to the finish, you're able to, you have the ability to really take certain steps during the process, allows you as a dentist to be confident in transferring those details into the patient's mouth. So it's just making everything, you work easy. um, this is the workflow. For example, if you need to replace a missing tooth, the central, so you need to measure, cut the fiber, okay, prepare the teeth, make sure you clean, etch, and bond. All right, and then apply your injectable composite and position your fiber. So in this case, I'll be using my silicone key. This is I think this is Flexseed, and I would use that silicone key to press against my fiber and reposition it and spread out the fiber to make it thin on the palatal area. So that would make it comfortable and thinner for the patient. And of course, you're bonding it properly all around the surface of the palatal area. Of course, you need to light cure that effectively. Normally, it's 40 seconds per area. And I would use a transitional fiber or a short fiber being placed at the center of my structure. This is really just to, if I have space, this is really just to reinforce my pontic. So when I start building up the pontic with my genial anterior, it's easier and it makes it a stronger structure. Okay. I also use the silicone key to help me build up the tooth. So again, transferring those details back into the mouth. And it just makes it easier for me to build it up because I have the right shape. I'm able to copy that from my wax up. And thereafter, it's like veneering. So you just apply your multi-shade layering. So I would normally use an opaque dentine on the cervical third and cover the fiber area with opaque dentine as well because of its translucency. I want to the opacity of my genial anterior to cover that so that there's, I will not be seeing any grayish on the middle thirds of the tooth. And then I put my standard shade dentine, do my anatomy, all right? And this is your last layer will be your enamel layer. And then don't forget, like I mentioned, you have to cover the fibers entirely with your injectable composite. So even the palatal area should be covered with the composite. And then treat it like a composite, polish, and and then of course you um, finish it and polish it very well. Okay, so case selection, again, you just have to think how many missing teeth do you need to replace? Is it on the anterior or posterior? Whether your abutments are healthy? Are you able to bond properly? Again, for your first case, always choose an ideal case. So check the bite of the patient, consider occlusal load, anterior guidance, and of course, patient education and compliance. Make sure your patient understands what the treatment option is. Okay. Contraindications, again, if this is, the teeth are misaligned, you have very mobile adjacent teeth or abutments, so you have to really consider risks. And of course, if the patient has poor oral hygiene, you need to make sure you address those issues first. Patient has severe bruxism, this is really not going to work. Or any other restorative treatment, so you make sure that you address those issues with your patients first before doing anything for them. All right. So again, longevity of this fiber reinforced. This is a fairly new study. It just really gives us a good indication. You have very good overall survival of this treatment approach. And of course, we want to wait for more long-term performance. But again, like I said, depending on clinicians, depending on the patients, this is something that is really viable. This is something that the patient um, can really live with. So, um, before ending this, I'm really just want to say that there are a lot of extensive clinical studies and reports that are available around this Everstick fibers. And this really just gives us that indication that we can this is a valid alternative for replacing missing teeth on the anterior or posterior region. So again, it's really versatile, and you have different fabrication techniques that you can do it directly or indirectly. How you're gonna go about it really depends on you as a clinician and what you're comfortable with. This is definitely a good solution for your patient. It can be a one visit bridge. You can postpone heavy prosthodontic treatments with minimally invasive restorations. You have, divided treatment cost, and of course, you can repair it easily, especially because it's composite. So again, this is very, very cost effective and economical for your patients. Importance of light curing: make sure that you light cure 40 seconds per area. Again, these are anisotropic in nature, so just make sure that you cure effectively. There's no way you can over cure it. Under curing is an issue, so make sure you cure all your composites effectively, making sure that you check your light curing units all the time. Okay. Some clinical tips: fibers must always be covered entirely with composite. Be careful not to cut the fibers during finishing phase. If you do, it's all right. Just, trim it properly. Treat it like a composite when you polish it. Attach the fibers for interior regions as incisally as possible. And also, you need to make sure that you keep, especially if it's inlay retain, keep at least 1 to 2 millimeters of thickness on the occlusal um, part of your bridge or your restoration. All right. So if you have any questions, this is my email address. You can reach me through this email address. And yeah, so this is the end of my presentation. So um, we can and go to the Q&A session. Sorry, it took a bit of I took a bit more time, but yeah, I wanted to cover as much as I can. So yeah, so you can benefit from it and understand how this material actually works.
Thank you, Dr. Castillo, and that was very well explained. Very simple, yet I could. It was like reading, going through the whole of the literature in one go. Not the entire literature, but yes, definitely the pointers of it. So thank you so much for explaining it so beautifully. It was indeed very lovely and very simple, I must say. All the steps, especially those clinical steps that you mentioned one by one, it was like we are doing it with our own hands. So thank you so much for that.
That's very nice.
So,
Thank you.
shall we go ahead with question and answer session? Shall I start with questions?
Sure.
Okay. Uh, do the if we are bridging the gap like between the two teeth, if we are using fiber reinforced composite and we are giving an pontic to the in between the tooth, if we are placing a tooth, so do we need to keep it out of occlusion?
Not necessarily. As long as the patient is biting well and no interference, that's fine. Because again, it can withstand those occlusal stresses, as long as it's not very heavy on that area. And of course, before doing any bridges like that, you have to check the patient's bite. If there's really extreme, there's not much space for you to place your fibers, you might need to do a little bit of preparation just so you can accommodate the fibers. But it's really, really thin. It's again, try your best to be minimally invasive in that situation. Yeah.
Another question, there is like most composites they stain over time. So what is the in these also fiber reinforced composite, when we are giving that composite plugs, is will they stain over time, and will they need retouching or repolishing of it over the time?
Yes, yes. This is really a limitation of our composites. And we understand that this happens. Patients come back to us, and then after, let's say, 3 years, the patient comes back, and then you can see a little bit of staining all around. So what we can do is resurface it. You can repair a little bit. Definitely, you can do that. But that's not necessarily removing the entire fiber. If it's still there, you just resurface, repolish, or top it up, or those things. So like a normal composite. Yeah.
Great. You have showed a case in which the adjacent teeth you have prepared, like molar you have prepared class one, and DO you have prepared. So Do we need to prepare in all the cases? Do we need to prepare the adjacent teeth, or we can?
If it's like a virgin tooth, like there's no cavity at all, we wouldn't, of course, we wouldn't recommend for you to prep the tooth like that. So we only do that if inlay retain when there are, cavities on both ends, on both sides. Um, for virgin teeth, you will go for surface retain, meaning you will attach the fiber on the, let's say, buccal and
Butter as well.
palatal side of the teeth, and not, not drilling a hole onto an intact tooth.
Okay. Some questions regarding these fibers. Actually, there's Dr. Chandramouli is also there. He has said, FRC Bridge Simplified, lovely presentation, awesome, simple, and informative live as always. Uh, then we have Dr. Um, Ajay Vishwakarma with us. He's asking if similar but self healing fiber reinforced materials are out there in clinics.
Sorry, again, what's the
Um,
question?
Similar but self healing fiber reinforced materials.
Self healing.
Right.
Um, what does it mean? You mean
Maybe he's asking about some biomimetic or something like that on those lines.
Okay. I think I will not pretend that I know what she's talking about, but to me, you need to make sure that you have enough information before using this type of materials. So
Yes, yes,
to me, if it's when you say self healing and all that, I need to make sure that it does work before I actually try it. But in situation like this, like bonding and adhesion and all this aesthetic work, this can this can definitely be a way or a possibility for your patients if you
yes.
want something fixed to be done for them. But self healing, I'm not very sure.
Yes. um, Another question, Dr. Castillo. Do we need to etch and bond the fibers as well? I think it's shown. No.
Because like I said, it's pre-impregnated, so it's like when you say pre-impregnated with resin, it's readily bondable with composite. So it's like a composite material. You apply your composite on top of it, it's going to bond. So what you need to etch and bond will be the tooth surface.
Mm. Dr. Nupur has asked, she found the GC fibers little difficult to handle. Any handling tips from your side?
Yeah, that's the reason why I actually use, the Flexseed, the silicone key, because it just makes it easier for me to adapt the fiber. I've shown you in the presentation as well those um, flat instrument that is wide. That's we call it stick stepper.
Okay.
It just makes it easier to manipulate. But like I said, materials you need to get used to them and how to handle them. Maybe Dr. Chandramuli can run a course and do a hands-on. Yeah,
Sure,
it's
sure.
it's it's really playing with the material first. That's why I always say choose an easier ideal case first so that you get
Right.
the confidence, you understand, and then thereafter you modify how you do things and it just makes it, better.
True. True. I think last question, how do you activate the composite in indirectly made bridges?
So what you're reactivating is not the composite but the fiber. So make sure that the fiber area, so those wings, like I said, in indirectly fabricated materials. So you just apply your stick resin on those stick resin on the fiber itself. So wait for 5 minutes, and then you can reintroduce and use your composite to bond to those fibers, um, and attach it onto the tooth structure. So you need a stick resin, a pure adhesive material to reactivate that surface.
Okay. Dr. Chandra is saying, sure, Dr. Castillo, a hands-on workshop can make it easy to understand the handling. So I think the next thing we are looking at is, a combined workshop from you and Dr. Chandramouli on how to handle these fibers and, learn more about fiber reinforced composite.
Yeah.
Having said that, Dr. Castillo, it was a wonderful presentations.
Thank you so
We are
much.
done with question and answer session. Um, big shout out to everyone, and thank you, Dr. Ajay, for being here. Thank you for Dr. Nupur for inviting everyone. Dr. Castillo for giving your time to us. Thank you so much, Dr. Castillo. Have a nice day, and it was a very, very, very informative and simple presentation. Thank you.
Thank you. Thank you so much. All right. Thank you.
So that was Dr. Castillo, and we have, there have been lectures about fiber reinforced composite, but I must say each presentation, and there will be some different takeaway points, because the speakers are not just talking about a material; they are talking about their experience, their tips, their tricks, and we all know, being in this field of dentistry, over the time we actually invent some of our tricks and some of tips and tricks that we can extend to the people out there. So thank you everyone who's been here and who has listened to this, and I hope it's as they say that learning is nothing if you don't implement it. So all these tips and tricks, especially in the presentation of Dr. Castillo, is something that we can apply. So let's not wait for it, and let's go, and whenever we get a new case, let's explore this material out. So thank you once again to Dr. Castillo for being here and speaking about this topic. The next speaker that we have, guys, you would have heard a lot about, throughout the conference. One thing that was constant was I telling you about Novolace laser therapy machine, Novolace laser therapy machine. So here we have the laser wizard himself, Dr. Chandrashekar Yavagal, speaking about laser dentistry. And as he says, laser dentistry is as easy as one, two, three. So to be honest, I don't know much about laser. Well, you guys must be thinking I don't know much about any of these things, but that's true. That's true. So I have used laser twice or thrice, but today it's like the whole world of laser will open in front of us. Dr. Chandrashekar Yavagal is a pediatric and laser dentist. He's an internationally acclaimed clinician, speaker, and PhD researcher on lasers, a university topper at BDS and gold medalist MDS in pediatric dentistry from RGUHS. He went on to complete his diploma in orthodontics from Spain. He is fellow of the International College of Dentists, associate fellow of the World Clinical Laser Institute, and diplomat of the International College of Neuromuscular Orthodontics and Gnathology, Italy. He is the only Indian dentist to be invited as a speaker and chairperson by World Association for Laser Therapy at France in October 2018. Presently, he is a professor and PG guide at MMNGH Institute of Dental Sciences, Belgaum, India. He is the India mentor of Asian Academy of Laser Therapy, vice president of College of Light Medicine and Laser Therapy, Germany. Dr. Yavagal has conducted more than 200 lectures, symposia, and workshops of lasers, pediatrics, and restorative dentistry all around the world. This presentation shall introduce us to an unknown phase of laser dentistry called photobiomodulation, which is currently the most sought after science worldwide. We shall understand lasers beyond the mundane and age-old concepts of cutting and coagulation. So let's hear it out from the laser wizard himself, Dr. Chandrashekar Yavagal. Dr. Yavagal, screen is yours.
Thank you so much. It's a pleasure being here. And a few individuals that I should thank before I start. Your awesome team at DRDCA 2020, Dr. Roxon, Dr. Nupur, Dr. Pallavi Mahajan, you guys are doing a fantastic job. I mean, the quality of the scientific sessions has been top-notch, and it's really a pleasure that I'm here to spend some time with you. I would also like to thank Dr. Sachin Manglekar, who's the CEO of Laser Futura Technologies, and all that hype around that bumper prize Novolace being offered as a prize for one lucky winner. All that is courtesy Laser Futura Technologies, and he's been generous enough to bestow his faith in me, and I'm blessed to have him here. So before I start, let's have some fun. Yeah, can I share my screen?
Sure, please go ahead. Yes, we can see you.
Thank you so much. So as Dr. Pallavi introduced us to the topic, laser dentistry as easy as 1, 2, 3, I would like to call this Laser Veda, and you will understand through the course of this session as to why Veda and why lasers together. Okay, like I told you, this is going to be a fun session. I'm not a, thanks for those kind words, but I'm basically a storyteller, nothing more than that. It's my job to tell stories. Half the time I'm on the stage, half the time I'm in a classroom telling stories to people. So let me see if I can entertain you on this beautiful Saturday afternoon. This story is called The Race. Yeah? So, what's this race about? This race is about two teams. They are not the usual cricket or the soccer teams, they are rowing teams. Yeah? Rowing is a beautiful sport. Once upon a time, there was an Indian rowing team. India and Japan agreed to do an annual rowing race, and it was decided that each team would comprise of 8 men. I have selected Japan for this story because I really admire their work ethic and their culture. If you happen to go to Japan anytime, Tokyo anytime, you will love their work ethic. So this is just for fun's sake. Please don't take it very seriously. India and Japan agreed to do an annual rowing race, and each team would have 8 men. Both the teams worked really hard to get in their best shape for the race. And the day the race started, both the teams were in a very similar condition. Both had prepared well. But the Japanese team won the race by 1 mile. So it was, a setback for the Indian team, and they wanted to understand why they lost the race. What was the reason? So the management showed unexpected wisdom. They hired the consulting team to restructure the Indian rowing federation, and it was understood that the Indian team had 7 captains and 1 rower. Awesome. The Japanese team had all 7 rowers. So facing this kind of a critical scenario, the team started working, and the management had a lot of analysis to do, and they decided that the structure of the Indian team would be changed for the next year. So kya hoga next year? Next year, the Indian team would have 4 captains in the team, led by 2 managers, 1 top manager, and 1 rower. Besides that, they suggested to improve the rower's working environment, and they decided to give him higher competencies. Amazing, isn't it? Any guesses as to what happened the next year? Guys, we lost the race by 2 miles. The previous year, the margin of the loss was 1 mile. This year, it was 2 miles. What did the two team do after that? Immediately displaced the rower based on his unsatisfactory performance. Sad. And the bonus award was, however, paid to the management for the strong motivation that the team got during the preparatory phase. That's what the managements are for. Now, the consulting team was hired again. Now, they said that for the next year, the new analysis says that the strategy will be the same, the motivation will be the same, but the used tool has to be improved or changed. So right now, the Indian team is designing a new rowing tool to win the race next year. Any guesses for the margin of victory or defeat for 2021, ladies and gentlemen? Jokes apart, now it's time we ask ourselves, are we any different? We are all a part of one or the other race all the time. All the time. We are a part of one or the other race all the time. The race to be the number one practitioner of the city, the race to be the most updated clinic of the city, the race to be the most tech-savvy professor of the college, the race to be the most accomplished postgraduate of a certain dental school, the race to be the best dentist in the town, the race to be the most advanced, most well-equipped dental center in the state. Races are never ending. And majority of us think that the tool that will help us win this race that we are all a part of will be a laser. Awesome. I beg to differ. We can't be farther away from truth. Like the story told us, there is no point embracing new technology unless it is based on sound fundamentals and a strong biological know-how. Otherwise, the result is going to be as catastrophic as we saw in the story. So the race cannot be won by changing your tool. The race to become the most accomplished practitioner post-COVID-19. 2021 is going to dawn a new era in the dental practice across the globe, and India is no exception to that rule. So you think that you're going to buy a laser and that's going to win you this race? You cannot be farther away from truth. I mean, I personally believe that as dental surgeons, we were supposed to be healers to begin with. Our job was to heal people. Somewhere along this journey, we got so obsessed with our mechanical concepts that sharp line angles and round point angles and flat pulpal floors became more important. The healing was conveniently thrown out of the window. The moment I say laser, light amplification by stimulated emission of radiation, it's a tool which a lot of us believe is going to be our passport to the future. A lot of us understand that it is fire. It is going to burn tissues like crazy. It is one tool which is going to cut something without bleeding. It is going to chop a mass without pain. It is going to leave a surgical site without sutures. Seriously, guys? Is that the limit to our imagination? Seriously? Well, at the end of this 1 hour session, if I can change that one perception that it is not so, then I think I would have done justice to the slot that I got at the DRDCA 2020. So let me see how I can do that for you. Let's have some more fun. Like I told you, I'm basically a storyteller. I'm going to tell you stories and stories and stories. And the end of it, you will. I hope you will get the message. So what's the next story? How many of you don't like this movie? And the magic and the fun and everything. Well, let me be very honest. All the magic for me in this movie happened around Hermione Granger. Nothing else. I was not interested in the vans. I'm still not. Hermione Granger is all the magic for me. But yes, Emma Watson, I admire you a lot. But a lot of us like this movie for the kind of magical effects that were shown, and the wand and the spell and the abracadabra and all those beautiful spells that would bring us those magical effects. We all love this, right? From 3 years to 90 years, everybody loves the Harry Potter series for the magic that it portrays. Now let me ask you something very simple. Have you ever felt that you could also do something magical in the lives of all those patients whom you see every day? If you can make a difference to the lives of all those patients, do something magical in their lives, would you not take it? Would you not be that healer again? Would you not earn to get that healing touch back, or would you prefer to keep cutting and, nothing against anyone, but yes, I mean, there is much more that we can offer to the society as dental surgeons apart from just cutting and stitching. Yeah, think about it. So in that movie, we understood that the wand could be used to hurt someone or to heal someone. Correct? The wand remained the same. You could use the wand to hurt someone, or you could use the same wand to heal someone. The choice was yours. The wand did not change. It was, after all, the tool. Something similar can be said about laser as a tool. It's the same tool, it's the same magic wand. It's up to you to decide whether you want to do or use it for some destructive purposes. I'm not saying surgery is destructive. I have been an accomplished laser surgeon for a decade now, and I would get patients from far and wide for my cutting skills. And then, unfortunately, the person who introduced me to this beautiful science, who lent me his hard-earned money to go and learn, when my dad was diagnosed with a CA of a certain kind, and he would get up every day in the morning with oral mucositis, and I was the one with a laser in my center. I was the one who was completely unaware of this beautiful science of photobiomodulation. I was the one who would take that damn Kenacort and that damn clotrimazole, mix it and apply it on his mucosa so that he could eat something, he could drink something that day. And I couldn't do that for long, lost him very soon. But after that, I realized that today, I am a star worldwide, speaking on oral mucositis and how lasers can heal people, and how lasers can be used for helping a patient who's battling cancer. I could not do that because I was an expert cutter. I could not do that for my own dad, and that is one regret that I'm going to die with. That's okay. But now it's my mission to make sure that I spread this message to as many people as possible. I want this legacy to be taken forward. I want India to represent and host the next World Association for Laser Therapy Congress in 2022, and we are working towards it. But yes, coming back to the point, for far too long, the world has only looked at laser as a cutting tool. For far too long. And I was a part of that gang, to be very honest. And things changed when I started understanding what exactly is laser, and what exactly is light, and what are photons, and what photons do when they interact with body cells and body tissues. Apart from cutting, what else can these photons do for us, is when I changed my perception about laser dentistry. Laser dentistry is not just about what you see on your screen right now. No drilling noise, no vibrations, no cross contamination, blah blah blah. These are basically substitutes for the scalpel and the drill, which I don't want to project. We are not looking for a substitute for the drill or the scalpel. So this particular slide makes no sense to me. What makes sense to me is the company of this guy who changed my perception about lasers, Jan Tuner, the man himself who first made me understand that laser is not a substitute for the drill or the scalpel, my dear friend. He used to tell me, I remember spending those 3-4 days with him at Nice, France, and let me tell you that I learned more about laser science with this man than what I understood reading all those PhD articles and books on the subject. So it's about not what you read, it's about the kind of people that you spend your time with, the kind of energy that they bring to you, the kind of positive vibes that you get when you are with someone is what matters. So it was that moment for me, meeting my hero, my guru. Photomedicine, as he says, is that area, that lesser known face of laser dentistry, which can make a previously impossible procedure a distinct reality in our clinical practice today. What exactly is he trying to tell us? What exactly is he meaning to imply? And that's the reason why now you will get the meaning of laser Veda: heal, educate, inspire. That's my mission, and I'm on that mission, and I'm glad that I can share a few things about that particular mission with you guys here today. So firstly, what is a laser? Laser is a kind of light. What kind of light? A pure form of light. What do I mean by pure? What do you mean by pure and impure light? Basically, light is made up of photons. It is known for its dual nature. Light exists in the form of particles called photons, but travels in the form of a wave. So that is the duality, that is the nature of light. So when we compare a laser with a torchlight or an ordinary light, basically a laser is made up of those photons which are collimated, that means they are going in one direction, which are monochromatic, that means they are made up of one wavelength or one color, and they are coherent, that means they are spatio-temporally correlated or spatio-temporally in synchrony with each other, in phase with each other. They are connected to each other. So ordinary light is the opposite of that. It just contains photons which are moving in all different directions, and it may not be monochromatic, and it is certainly not coherent. So when we use a monochromatic, coherent, collimated source of light for therapy, that is what is laser photobiomodulation all about. Now you can see on your screen a diabetic foot, badly damaged diabetic foot with an ulceration. Sometimes, these patients have to lose their entire foot. They are amputated so that the infection doesn't spread further. Now that can be reversed by using monochromatic, coherent and collimated beam of light, which we call it as a laser. How does that happen? And how can light help us? Let us try and understand this. Let us change our perception about what lasers can do and what lasers cannot do. Firstly, we remember this, right? In our primary schools, we understood that the plants could use light from the sun and produce their own food, photosynthesis, correct? These plants which exist in nature, they are not subjected to the kind of antibiotic applications that we humans are subjected to. Yes, but they still survive, right? You think they don't get infected? Do you think the plants don't suffer? You think there are no diseases in plants? How is it that they are able to manage themselves without antibiotics? Think about it. What is it that heals them? What is it that sustains life? In one sentence, it is light which sustains life. How? Why? Is what I'll just try and share with you. Basically, the same concept works in humans. When you talk about the electromagnetic spectrum, there are certain wavelengths on the electromagnetic spectrum which have got special ability to heal body tissues. You call this as the energy medicine, or you call this as some kind of a healing which is light based. Basically, what's happening is that the take home message is very simple. Any cell, any tissue, any organ in the human body can heal when we create an environment conducive for their healing. How does light produce that conducive environment is what we'll see in the next part of this presentation, because before we go further. So let's focus on the near infrared and the visible range of the electromagnetic spectrum, which has got the maximum healing benefits for dentistry, starting from endodontics to orthodontics. Now, these are not fancy numbers that you're seeing on the right-hand side of your screen. These are PubMed indices, PubMed references for what I'm saying. Specialty-wise, you can see on the left-hand side, the specialty is indicated, the application is indicated in the center. What laser therapy can do for those applications is also listed, and there are the PubMed references for each and every point that is being told here. Now, let's look at some interesting ones. Oral pathology, burning mouth syndrome, herpes simplex virus, lichen planus, oral mucositis, like what I told you, xerostomia, TMJ pain, TMJ trauma, mandibular distraction, pulpal problems, dentinal hypersensitivity, paresthesia, alveolar nerve damage after a third molar disimpaction, accelerated orthodontic tooth movement? Seriously, light can accelerate orthodontic tooth movement? Don't believe me? Give me another 30 minutes and then maybe I'll change your perception about it. Coming to my field of specialization, pediatrics, how you can reduce pain, how you can enhance healing in pediatric dentistry, periodontics, how you can reduce inflammation, enhance healing, how you can improve the pocket depths without even raising a flap. Let me try and make that understand. Last but not the least, implantology, how a beam of light can enhance the bone implant interface strength. Right? Now, for us to understand this, now if there must be some critics in the audience who will be telling that how a damn beam of light do everything. Is it a panacea? Well, it's not certainly a panacea, but for us to understand how light can heal, we need to first understand what is health. What is health according to our understanding? We don't want the WHO definition for the health. What we need to understand is that our human body is made up of millions and millions of cells. Many cells put together form a tissue, many tissues put together form an organ, many organs put together form an organ system, and many organ systems have to function in tandem with each other for the organism to survive. That's life, that's health, correct? That's not rocket science. What happens when a cell gets diseased, infected, inflamed, or simply old? A cell starts affecting the quality of its own metabolic activities because it starts producing nitric oxide, and there will be a sudden drop in the production of adenosine triphosphate. So that adenosine triphosphate is the energy currency without which the cell cannot survive. So when one single cell dies, nothing happens. But there are many, many clusters of cells dying. The quality of the tissue comes down. When the quality of the tissues comes down, the quality of the organs that they made up of comes down, and overall, the health of the organism is affected. Is this rocket science? No, it's not. It's simple biology, right? Now, we have these friends, these tiny little mitochondria, which are the energy powerhouses of each and every cell in the human body. We had learned this during our first year anatomy, biochemistry, but we never took that very seriously. Neither did I. I used to hate that biochemistry professor of mine, but now I regret. So what has to happen is that these mitochondria are the factories which generate the energy that is needed to run the whole system. Now that factory generates what is known as an adenosine triphosphate, and that adenosine triphosphate, ATP, that's the battery, that's the cell. So these mitochondria are tiny little factories which contribute to everything that the human body goes through, from cell division to multiplication to DNA replication to, from A to Z, including our immunity is dependent on how well our cells are functioning. We are talking about polymorpho-neutrophils, we are talking about B lymphocytes or T lymphocytes or any line of human immune defense. What matters is the quality of the ATP that the cell is able to produce. Now, the best part is that there are certain wavelengths which can be used to elevate the energy levels of these cells by stimulating ATP formation. How does that happen? It's very simple. It's the law of photodissociation. I told you, whenever a cell gets diseased, infected, or inflamed, or simply old, it starts to produce nitric oxide. That nitric oxide prevents an enzyme called cytochrome C oxidase from participating in the Krebs cycle. Because the Krebs cycle gets affected, ATP production drops. The cell is unable to produce enough energy to carry its own activities, and that's the reason why the quality of the tissue activity comes down, the quality of the organ systems comes down, and the health of the organism suffers. What if we could reverse this? Use a beam of light, use photons to stimulate cellular functions by stimulating ATP production by a process called photodissociation, which cleaves the bond between cytochrome C oxidase and nitric oxide. So is it something magical that is happening? No, it's just a photodissociation. The moment that photodissociation happens, the cytochrome C oxidase is free again to take part in the Krebs cycle, and it starts producing ATP again. that ATP is the energy that the cell wanted, right? It did not ask for antibiotics. It did not ask for antivirals. All it wanted or all it needs is ATP, and that we are providing through photonic energy. And this, ladies and gentlemen, is what photobiomodulation is all about. I could not simplify it further in the little time that I had, but I hope I could make some sense out of whatever I could. So basically, this is what it is. Let's not go into too much detail about what each wavelength of light can do, but that's just the entire gamut of PBM light-based applications for you, starting from the green and the blue and the near infrared. Let's today focus on red light therapy to begin with, how it will stimulate ATP production in cells, how it can help us in membrane repair, TGF beta, transforming growth factor beta, how it will help us in correcting or healing wounds, tissues, how it can help us through the TRPV1 gateway to alleviate pain, how to control the pain in various structures in the body, how to change a pro-inflammatory cascade to an anti-inflammatory cascade. So it's basically pain reduction, analgesic effect, anti-inflammatory action, and superior healing. So let's try and understand how we can use this for our day-to-day clinical practice. That is what laser dentistry is all about, and it's pretty simple. It's as easy as 1, 2, 3. Let me try and show you how we can use that for our day-to-day clinical applications. Look at this lady suffering from this lesion on the tongue. She had a candidal patch over that. It was erythematous. She could not put a bolus of food on her mouth. And then what we did was a simple photobiomodulation therapy for her, and that was the effect after 4 sessions. Now, this is just one example. The list is endless. Actinic cheilitis, free laser, and after 4 rounds, young lady. Look at the angry texture of that tissue, pre and post. Now you need not be astonished looking at the results, because you know at the level of the cells what is happening. Now these cells, which comprised of this tissue on the lip, were struggling to recover because their ATP production had dropped. Why it had dropped? Because of either inflammation or an allergic irritation, or it's an autoimmune reaction, or in this case it was actinic cheilitis. The lady was advised not to go into sunlight, but it was not possible. So what we did was a simple photobiomodulation laser therapy, and after 4 rounds the cells recovered. How did they recover? Did we apply anything over that? No, it was just plain light. What did we do? We used it to enhance the healing. We supplemented it with the ATP which was missing, and the moment the cells started producing ATP, they were back on track. They did not need any external source to heal themselves. Like I told you, any cell, any tissue, anywhere in the body can be made to heal if the environment, the right environment or conducive environment for healing is created. This is a classical example of that. Post-surgery radiation CA retromolar trigon. This was months old when the patient came to us, and that was the pre-laser, immediate round 1, round 2 on day 3, and round 3 on day 9. So what had not healed for 9 months, how did it heal in 9 days? It is basically very simple. We have for far too long been dominated and manipulated by the pharmaceutical industry. We have got that thing etched in our minds that unless we use a pharmaceutical agent on these lesions, whether they are in the mouth or outside the mouth, we cannot accomplish adequate healing. Now that we can't be farther away from truth, and the next decade is going to be dominated by an era of photoceuticals, using light, using lasers for healing tissues, and this is a classical example of that. Let me quote my favorite researcher, Tina Carew, who says that you can speak to each cell in your body provided you know the right language. What language is she talking about? She's talking about the language of light. And what the language of light can do, the pictures are telling the story to you. This is how we use it for cancer-induced oral mucositis. This is what exactly I was not knowing when I had a cancer patient in my home. But then in due course, I understood that this is what works for oral mucositis. Now, It is a standard of care. The National Institute of Craniofacial Research in the US has made it now mandatory for all chemo and radiation patients to first undergo prophylactic photobiomodulation or laser therapy before they go for their chemo or their radiation. So we are now launching a new protocol called the Laser Healing Triangle. The new fellowship students of our academy will be trained on how we can use these concepts in synergy, how we can use different wavelengths, how we can use different topical agents, which will be driven further through the laser therapy, and how this laser healing triangle works. We are getting excellent results with oral submucous fibrosis. I don't have time for the details, but I can definitely run you through a few cases. This is a young child who was diagnosed with Stevens-Johnson syndrome. He's the son of a principal of a homeopathic medical college here in my town, and sad story that that at one point of time he was on 6 different anticonvulsants. 6 different anticonvulsants. There was a time when he would throw a fit, he would get an epileptic seizure every 1 hour. So to control that, a 7th drug was added, which was carbamazepine, and 24 hours after using carbamazepine, he ends up with this kind of a lesion on his lips, on the oral mucosa, completely burnt off, literally, and he could not sip a glass of water. We started with red light therapy for him. This was 48 hours after the first session, right? And this was after 5 rounds on 5 consecutive days. Please pause for a moment. Let that sink in. Which plastic surgeon in the world can give you this kind of a result in 5 days? Think about it. And then think about which frenum you were planning to cut after attending today's session. I still love surgery. I'm not against it. But then, like I said, that should not be the limit to our imagination. We were supposed to be healers to begin with. And this is one way how we can get that healing touch back. If you agree with me, use the chat box and say, yes, doc. Of course, I don't have access to that chat box now. I'll be seeing it at the end of the session when we will be opening the session for questions and answers. I'll be more than glad to answer a few of those questions for you. So it is one of those OMG moments, right? If you like this, use the chat box and write OMG. I mean, if you can do this with somebody's life, this is what I say by making a difference to someone's life. This is what it is. Especially when you do that for a cancer patient, I keep repeating this time and again, you cannot add more days to a cancer patient's life, but you can definitely add more life to his or her remaining days. Does that sink in? You cannot add more days to a cancer patient's life, but you can definitely add more life to his or her remaining days. Again, if you feel those goosebumps, write OMG in the chat box. So coming back to magic wands, so what am I trying to tell? Am I trying to tell you that use your laser like a magic wand and say abracadabra and everything will open up? No, it will not. Just like there are different wands for different spells, there are different wavelengths for different effects. The wavelength is the culture, the pedigree of the photons that make up a laser beam. So, if you say expecto patronum, what happens in Harry Potter? Any guesses? Expecto patronum. That's a defensive charm, correct? And it is meant to protect you against the dementias by summoning one's happiest memories. How do we know this? That's a fact file. Similarly, we need to know when we use a certain wand or a certain wavelength, what is the protocol? What wavelength to use where? You can't use Harry Potter's wand and say a spell like expecto patronum. It doesn't just go well. It doesn't just match, right? So, similar is the case with lasers. One wavelength cannot do everything for you. There are certain good wavelengths for ATP production, typically in the 660 to 810 range. They are the ones which are widely used for enhancing ATP production. As you go towards the 1000 mark, your surgical skills will improve. And as you come towards the 600 mark, your healing skills will improve. That's why my personal choice is always the 810, because it gives you the best of both the worlds, right? It's right in the center of 600 to 1000. What else can 810 do for us? Well, pain relief, pain therapy, whether it is TMJ pain, whether it is craniofacial pain, whether it is a trigeminal neuralgia. You don't have to simply refer the patient to a neurologist or to a psychiatrist thinking that the patient is fabricating pain. Nobody does that. Pain is real, ladies and gentlemen. If you've gone through something painful in life, you'll realize that you can't fake pain, right? You cannot. Although you can fake that you are healing, you can fake that you are recovering, you can't fake pain. So it has taken us more than 1000 years to understand this. And today we are using this for various applications, especially the 810 with a laser, without a laser, coherent, non-coherent, for TMJ pain, craniofacial pain. Again, the list is too big. I can't give you all the details in this 1 hour session, but I can definitely run you through some of my clinical cases. Have a look. I'll share some protocols with you. Please have a look at this. It's one of my recent cases where I used an 810 for TMJ pain. This was a very peculiar case. I'm still treating this lady. For her TMJ problem, her pain, came down immediately. After 2 or 3 visits, her TMJ pain was gone. It was down. But unfortunately, she suffers from trigeminal neuralgia as well. So I had a different protocol for her. This is one of my recent cases where I've combined strategies. I've used the 810 on the TMJ. I have used an intranasal device. I have done a lot of auriculotherapy for her, all with different wavelengths. Let me share those things with you. Now, this is what is my new found device from Slovakia. This is called the BioQuant, which will be again launched in India very soon under the Novolace banner. And this is the device that they are using for transcranial irradiation to control the brainwave activities in Alzheimer's patients, in Parkinson's patients, in patients who have just recovered from COVID-19, but they still feel that they are weak or their immune system is not up to the mark, or if their health is not up to the mark. This is the latest from Slovakia. I want to share that with you. This is intranasal red light therapy, and this is not a laser. This is what is known as a polarized LED. So this can be given to the patients as a home care device. It's a polarized LED. Yes, for the laser pundits also. This is a new thing. I don't have the time to explain that for you here. Maybe sometime. Polarized LED is going to be the future of therapy, because for people who cannot afford a laser, polarized LED is going to be the next thing. This is how it works. After this, her requirement for carbamazepine for her trigeminal neuralgia came down from 1 gram to 200 mg. She just takes that Tegretol 100 mg chewable tablet, 1 in the morning, 1 at night. That's it. And her therapy is still on. She still feels that, there is a little bit of pain sometimes. So basically, she needed a serotonin boost. She was having borderline depression, and apart from analgesic effect, I needed to pump into her endorphins and enkephalins to make her feel good about herself, to pump those serotonin uptake hormones, which will make sure that she feels good about herself, and that will change her perception about pain. So pain for far too long has been considered on an objective scale all the time. but please understand that how you and me react to pain is extremely subjective as well. So the best way to do that is to use a laser device for what is known as auriculotherapy or laser auriculotherapy. You can see the example here. So those 3 points which I treated on her auricle are the Shenman, the muscle relaxation point, and the analgesic point. Again, too short a time for me to explain how the Shenman works and how laser auriculotherapy works, but it works amazingly well. And maybe if I get a chance in future to talk to you about exclusively about laser auriculotherapy, what all diseases we are treating, from post-COVID immune rejuvenation to transcranial traumatic brain injury recovery, anything and everything is possible with light. So for those who don't want to try out these different things, who are happy doing their regular stuff, you can use photobiomodulation or laser therapy after regular extractions. Trust me, do this tomorrow and your patient goes back home without a single painkiller even after a full mouth extraction. Don't believe me? I'll be giving you my phone number. I'll be giving you my email ID. I'll share the settings with you. Please do this with an 810 100 milliwatt setting and do that for 2 minutes on the buccal vestibule of the tooth you have extracted and 2 minutes on the palatal side of the tooth which you have extracted. Don't give a single painkiller to the patient. Send the patient home and give your number to the patient and tell the patient to ring you up if he or she gets any pain. And if he rings you up, the next thing what you will be doing is you will be ringing me up and telling me that, doc, your protocol did not work. I'll be more than glad to accept that. Okay, please try this. Buccal and palatal, this is how it works. Like I said, you don't have to be worried about settings. Now I told you 100 milliwatt, 2 minutes. How will you get these things? How will you get the dosimetry right? You don't have to get it right. Today, laser dentistry is as easy as 1, 2, 3. You just get every damn thing on your screen. You just have to select. You see that one there. One has got 3 channels, P1, P2, P3. Just select the one and your job is done. It will automatically take you to 100 milliwatt. It will automatically take you to 2 minutes. All that you got to do is hold it on the buccal side of the socket that you have extracted, of the tooth that you have extracted, and 1 minute or 2 minutes on the palatal side. This is what I mean when I say laser dentistry, as easy as 1, 2, 3, right? In fact, you can do that to treat paresthesia after a third molar disimpaction, right? Anything is possible if you've got enough nerve is what the lady says, and yes, it's possible. How do I justify that? You can see on the right-hand side of your screen, Schwann cell cultures, Schwann cells before PBM, before laser therapy, and see the same Schwann cells rejuvenating and, showing the color on the bottom of the screen after laser therapy. Now, what were we told in our dental schools? That if a nerve is damaged, it can never recover. Now it's turned out to be a myth now. Like I said, any damn cell anywhere in the body can recover, can heal if we are able to produce an environment conducive for their healing. Now, quickly moving on to the next part, wherein sometimes we need to use an activated photosensitizer or a dye before doing laser therapy, because plain laser therapy in a non-thermal mode cannot directly kill microorganisms. It cannot kill microorganisms inside a periodontal pocket. It cannot kill microorganisms inside an endodontic canal when it is used in a non-thermal mode. It can do that in a thermal mode, but in the non-thermal mode, if we want that antimicrobial kill then or antimicrobial effect, then we need to tag that with a dye. You can't simply choose any dye or any wavelength. Again, they have to be having an optical affinity So basically, the future of periodontology and treating peri-implantitis revolves around what is called as photodynamic therapy. For far too long, the world has chanted periogreen, periogreen, periogreen. Now it's time for Novogreen. This is the first Indian indocyanine green material that is available with a dedicated device. All that you got to do is use the dye. The dye is already mixed for you. You don't have to have those additional skills to understand how much mg needs to go into how much ml of the liquid, and you don't have to be scientists. It's enough if you can be good healers. So this is how you use it. The future of laser dentistry is definitely green. That applies to peri-implantitis also. All that you got to do is put the dye inside a periodontal pocket or around an implant, and the setting is already there. We saw what the one could do, right? Laser dentistry as easy as one. Now what can the two do? Two is green. Simple. Just press that. It will by default go into 300 milliwatt. Why 300 milliwatt? This is the pioneering alternative to standard treatment methods. This is 300 milliwatt, which has been proved. You have to just place the dye inside the periodontal pocket. Don't raise a flap. Just use your 810 contra tip on the gingival papilla or on the periodontal pocket from the vestibule, and you're done. Magical, isn't it? You can use that for implantology also. This is one of my very old cases where we had to place an implant the immediate day after the extraction was done. The socket was completely infected, so we could not place the implant on the same day. So we used PDT for disinfecting the socket. Here we used a different strategy. We used a blue dye. We did not have the green dye that time, so we used a blue dye. When you are using a blue dye, you need to tag that with a red laser, a 660 laser, and not with a 810. Now that is also available today. And after you do that, you can use the same 810 for enhancing the osseointegration of those implants. This is one of my recent cases where we loaded around, what? Close to 18 implants in that patient. And look at him. He's like hardly any feeling at all. No pain, no discomfort, no swelling. This is how we do it. So like I said, give me red. If you are using a blue dye, you got to use the red wavelength. If you're using a green dye, you got to use the 810, right? Next, moving on to conservative dentistry and endodontics. I know there are a lot of endo enthusiasts here, and let me assure you that the future of three-dimensional endodontic disinfection revolves around photonics, because photonics has lit up the entire field of endodontics. You can use any fancy file system, 3 files, 2 files, single files, reciprocating motion or rotary. Ultimately, the success of your shape depends on how well you irrigate your canals after that and how well you are able to disinfect the canals. By using the right kind of photonic device or by using the right laser, you can go 1000 micron laterally into the dentinal tubules. Mind you, ladies and gentlemen, I'm not talking about that damn MB2 or that one missing accessory canal which you cannot find. I'm talking about going 1000 micron laterally into the dentinal tubules of your main canal. Beat that. So if you talk about three-dimensional disinfection, this is the only way how it can be done. You can either use it in photothermal mode, or you can use the dye and the PDT protocol, just like the way we used it for implantology and periodontics, right? So that's how we do it. Photo-activated disinfection is very popular amongst endodontists. I know that they use this device, which is based out of 660 nanometer wavelength. That preset is also available now with the blue dye. You just have to simply put the dye inside the canal and use button 2, that is PAD, photo-activated disinfection. It will by default take you to 200 milliwatt. You need to hold it on over the access cavity, not even inside the canal. Beat that. And it will give you a 99.99% of bacterial kill, including the dreaded Enterococcus faecalis. So quickly moving on to the last part. How much time am I left with? Oh my God. Pediatric dentistry and orthodontics, we pedodontists are obsessed with pulpotomy. We start our journey by defining pulpotomy, and we have been searching for the holy grail of pulpotomy for close to 100 years now. That is what Formocrosol does on a histological section. You can see the inflammatory cells there loaded all over the slide. That is what MTA does. That is what Pulpotec will do. And look at the 660 nm laser. Hardly anything, right? No inflammatory cells, nice and clean. That is what pulpotomy is all about. You're not supposed to fix anything in pulpotomy. You're supposed to allow the radicular portion of the pulp to heal. That is exactly what your quintessential pulpotomy looks like. You could use this same strategy in a very low power for doing teeth whitening. Nobody likes the yellow. So this is a new concept which we have introduced called the Novo Synergy, wherein we combine a PDT dye with an ingredient which has got titanium dioxide so that it gets activated with the laser. But we are using an extremely low power to keep it free of sensitivity, and we will be simultaneously releasing calcium peroxide. Yes, you heard me right. Again, some pundits of laser science here who are listening to me, have you all heard about calcium peroxide? Hydrogen peroxide, yes. Carbamide peroxide, yes. Calcium peroxide is news, isn't it? Yes, that is news, and that news will be all over the place come Jan 2021, when Synergy and Novo will together unleash a new range of whitening products where whitening can happen without a zoom light, without a beyond polus machine, without a surgical laser. Stay tuned for more updates. Now, what setting will you use for this? 1 is over, 2 is over. Now we come to 3, aesthetics. Just tick that and it will by default take you to the teeth whitening mode. You don't have to know the entire science about how calcium peroxide will go and attack the carbon to carbon double bonds which give the perception of yellowness to a stained organic molecule. You just have to tick that aesthetics, it will do the rest for you. That's why I say laser dentistry is as easy as 1, 2, 3. Orthodontics, we can use the same device for accelerating orthodontic tooth movement. Unfortunately, I don't have time to explain the mechanism. It is based on the rank-rankle osteoprotegrin based system, and it's already in place. We are using it with 100 milliwatts of power, and we just use this on the distal aspect of the tooth that needs to be retracted. That is a canine for you, as you can see in this picture. That is the canine retraction that is being done. I mean, the retraction is already in place. We are stimulating it. So just how far can we think of going? Let's have a quick peek into the future of laser medicine. That's Professor Michael Hamblin for you at the Wellman Center for Photomedicine, Massachusetts General Hospital, right? This guy is doing so much of work on transcranial brain irradiation for treating Alzheimer's, for Parkinson's, for neurocognitive disorders. He has done path-breaking work on how we can use photobiomodulation for stimulating myeloid stem cells, how we can stimulate megakaryocytes, and how we can stop the platelets from dropping in a dengue patient. Beat that. Yes, it is possible. Very, very possible. Right? And that is the kind of future that we are looking at. That's what I said. The future belongs to light medicine. Hold on. What is this? It looked like a coconut shell to me. When I say, what's the limit to your imagination? This is my business development associate, Dr. Baswant Reddy. This is his limit to imagination. He's a very kind guy. He's very kind to every human being except me. And he's very kind to his animals. So this is his tortoise. And what happened one day was that this tortoise was run over by a car. You can see the shell there, dark. It was injured. The tortoise was struggling, gasping. What did this guy do? He doesn't take my calls and he does these things. He was busy treating his tortoise with a therapy device. And look at that tortoise now. Look at the change in the color before and after. Now you know what he must have done at the level of the cells. This is just pure ATP therapy or energy medicine, as you can call it. So when I say limit to your imagination, this is also the limit to your imagination. And he's definitely going to head my veterinary division in future for sure.
scientists discovered that laser treatments accelerate the body's ability to heal. Delivered at the right frequency, duration of time and location, it was discovered that infrared laser light interacts with tissue at the cellular level, producing a photochemical reaction that results in an increase in the production of ATP and improves cellular function and health. This technique is known alternatively as photobiomodulation, cold laser therapy and low-level light therapy. Photobiomodulation has impacted the scientific community's approach to healing damaged tissue, offering a better, faster, pain-free technique to treat a wide range of medical conditions that are dependent on tissue regeneration. From advanced pain relief to accelerated healing, enhanced range of motion to reduction of inflammation, laser therapy is now a first-choice treatment option for a wide range of ailments including sports injuries, chronic pain conditions, and post-surgery recovery. Many surprising applications for this treatment are now being implemented successfully, including the treatment of a variety of cognitive disorders, including ADHD, Tourette syndrome, concussion, stroke, and traumatic brain injury.
So that's one of our participants who's trying whatever I said was working or not working. So you don't need a different set of device for sports injuries or physiotherapy. That's one way of diversifying your practice. So you can use the same laser. All that you need is a different attachment, a different handpiece, and you can use that for physiotherapy applications also. So now, what is this? Have I confused you all? So am I talking about a different set of laser devices altogether? We has had the notion that we could use lasers for perio-endo surgery. So am I talking about a different family of lasers? No, not really. You can still use the same laser for surgery. We are still left with the 4. We did the 1, we did the 2, we did the 3. 4 is surgery. Tick that. It will automatically take you to S1, S2 or S3 depending on the severity or depending on the power that you need for a particular surgery. That's why this is a smart option, and this is how it looks, nice and beautiful. That's the 810 on a polyamide fiber, not a generic glass silica fiber that the generic units offer. This is a polyamide which can be bent to any angle, and that's how you can use this on any patient. The youngest of mine is this tiny little tot whom I treated last maybe a month ago, and she was what, 11, not I think, yeah, 11 days old, with that natal tooth which was attached to her lower occlusal ridge with a mass, and this was done without an anesthetic, not even topical anesthetic, only PBM, and then I changed the tip and used a surgical tip for that, and that's the healing for you. That's by far the youngest that I've treated lately. So now comes the big question. Can we afford lasers, and can our patients afford lasers? I'll answer the second part first. Do you really want to see what your and my patients can afford? Right? I'll show the patient affordability part first, and then we'll come and discuss whether you and me can afford lasers. I'm sorry for the delay. I'm just going to take 3 minutes more, and then we open the session for questions and answers. First, let me quickly run a beautiful video for you to tell you what your and my patients can actually afford. Well, I'm not talking about the consequences because they are a little complicated right now. Have a look. Wealth is where you least expect it. So the next time you judge a patient as to whether he can afford a certain procedure or a certain technique, please remember this video. I need not say more, right? Affordability is all about priority. Let me sum it that way. Now, can we afford lasers as dentists? Difficult question, but simple answer. If I can afford it, you can definitely afford it. How do I say that? Well, who am I? It matters not what someone is born, but what they grow to be. That's what the world talks about when they talk about me, the Forbes guy, the first Indian dentist on Forbes. No, that's not the truth. That's an illusion. Let me share that with you today. Let me be very open and very candid. That is not Chandrashekar Yavagal. You know who is Chandrashekar Yavagal? Hold on for a second. This is Chandrashekar Yavagal. That is my 4x4 chawl where I grew up. That is the Forbes guy, right? Between that 4x4 room of mine and Forbes, ladies and gentlemen, life happened. You see those torn slippers there, you see those torn clothings there. Between that and between Forbes, life happened. I won some, I lost some. I still keep winning, still keep losing, but I'm not complaining because I'm grateful to God for whatever He has given me and whatever He keeps giving me. Always eternally grateful. That is what I do. That's the id ego super ego moment for you. That's my dad's chair where I sit and spend all my beautiful evenings. And this is when I get all kinds of thoughts, good and bad, memories, good and bad. This is where I sit and draw things, crazy things like how the next Novolace display will look, what will one do, what will do two do, what will three, what will be the PCB design, what will be the laser output, what will be the foot pedal, and ultimately the result that we get will be something else. So basically, you need to keep dreaming, you need to keep thinking that the Tesla of laser dentistry is coming soon. The story has just started. And I want to see you again. Before I close, I want to thank DRDCA, the board, the directors, Dr. Roxon, Dr. Nupur, Dr. Pallavi Mahajan, and the entire team, Dr. Sachin Manglekar again from Laser Futura Technologies for being gracious enough for sponsoring the bumper prize, which will be announced tomorrow. And I love you all. Connect with me on Facebook. That's the only page that I manage personally. All the other Twitter handles and Instagram handles are managed by my PR team. But if you want to get candid with me, but get personal or send a message, that's my number. That's my email ID. And remember, connect with me on Facebook. That's the only page that I manage on my own. And it was a pleasure being here. I hope I have done justice to the 1 hour that was given to me. The hype around this talk was too much. And so much that I was so tense that I literally by mistake deleted my presentation last night. Today morning got up at 3:30 again and redid the whole thing. But that's what I love doing. This is my passion and I live for this. Pleasure being here, and I open the session for questions and answers. Sorry for overshooting, and very sorry.
Not at all, not at all. And it was, I'm glad that, all the talks around this topic, because it was a much needed, and I honestly did not know that laser would do so many things. Leave this dentistry part. Okay, I'm an endodontist, so I have read the application of laser in endo. But other than that, so many things. Thank you so much for enlightening us, I must say.
Pleasure is always mine.
And Walt Disney said that all our dreams can come true if we have the courage to pursue them. So that's what you have done. So thank you for pursuing your dreams and igniting those choti.
That's what life is all about. That's
Yes,
what life
yes.
is all about. It's a ripple effect. You do something good to others, the good will come back to you in multiple ways, and
Yes.
I firmly believe that.
So thank you so much, Dr. Yavagal. Can we go ahead with question and answer?
Sure. Please.
Okay. So the first question that we have is there enough research on what specific cells are responsible for these immunomodulatory observations?
Absolutely, they are cell specific. They have been tagged, and we have got specific cell lines which respond to specific wavelengths, and the data is available. I'll be more than glad to anybody who wants to read that. I'll be more than glad to share that information with you.
Okay, okay. Any potential adverse effects at single nucleotide duplication level after repetitive long-term use of the laser?
How do you define repetitive long term? Because basically we talk in terms of dosimetry. We talk in terms of how much dose is given to a certain particular cell line. So if you say repetitive, it makes no sense unless you talk about the energy. So if you say 2 joules, 4 joules, 6 joules, 8 joules, if you ask me at what level the effect could turn out to be detrimental, maybe yes. But long term has got no real meaning in this, because we need to talk in terms of energy. But yes, coming to the clinical side effects, none, because the cells are not greedy like humans. Basically, only the cells which are hungry absorb that energy, the others just don't. So that's just a superficial way of looking at it. But on a serious note, yes, except for a potential ophthalmic damage, there is nothing much that can go wrong with laser therapy.
Okay, there must be a particular protocol for every patient, how many sittings we have to
Yes.
call patients.
Yes. We have the protocol right now. You can access that on the Vault website. And very soon we'll be coming up with a Laser Veda app, which will be free to download. And I'll be more than glad to share that with all of you. The Laser Veda app has got presets for every damn thing. So laser dentistry will not just be easily affordable. Now, most of these therapy units are in the affordable range, which they weren't a few years ago. Same way, for people who feel that laser dosimetry is too complicated, we are coming up with an app. They just need to feed the clinical signs and symptoms and the diagnosis, and the app will suggest the wavelength, suggest the dosimetry, suggest the number of sessions, suggest the dose per session.
Okay, that's great. Looking forward to it actually. And Dr. Yavagal, if I may ask, those will differ according to the procedure. But
Yes.
does it differ according to like specifics of patient, young patient, old patient, immunocompromised patient?
It
Any
does. It does. Again, it boils down to what chromophores are we looking at. So
Okay.
chromophores are basically the elements which absorb the dose. Now, typically, just to say that you are treating something on the skin, how much dose you will use for a dark patient versus how much you use for a patient whose skin color is light differs. Same way, it's just not melanin. It differs with the kind of chromophores that are there in a certain region. But the best part is that since this is in a non-thermal range, you cannot cause any irreversible damage to any of the cells. So you can be in the range, that's more than enough. As long as you are in the middle of the window, that's okay. A little bit on this side or a little bit of on the other side, it's not going to matter much. Let me explain it in a different way. We all know that Dolo 650 works, correct? Just giving you an example. That doesn't mean that if you cut Dolo 650 into 2 and take half of it, you think it will not work? It will, as long as you are in some range. The same way, Dolo 700 will not kill the patient.
Right.
There is no Dolo 700 though. Even if you pop 2, you
will
probably,
nothing.
so that doesn't mean that you keep popping, but as long as you are in the window, you're fine.
Okay. Do we get a training on usage of this machine? And is it a single machine which covers all the treatments?
No, it's not a single machine, but yes, there is one versatile machine which can do everything.
Okay.
That's the surgical part, the PBM part can be done. The PDT also can be done, because it's not about the machine, it's about the wavelength. So
Right.
it's an 810 which can be used for PBM, it can be used for PDT, it can be used for surgical cutting also.
And as you said, the details of what wavelength to be used, where is all available, right?
Yeah. Now, like I said, the few things which I shared are
Right.
based on what we generally use in a day-to-day clinical practice. But then, as you mature as a laser clinician, as you have more wavelengths to work with and more kind of clinical indications, you tend to add 2 or 3 wavelengths, and that's how you mature as a laser specialist. To begin with, one wavelength is good enough.
Right. As an endo, I have to ask this question. If I get a case in which a lesion is there, I'm using laser for disinfection. So, to reach into that lesion and start the healing, other than disinfecting, do I need to use a different wavelength for when I enter the bone or the lesion part?
I'll give you a simple protocol for endo. Now, I'm not
Okay.
even asking you which laser you're using, which wavelength you're using. Doesn't matter. I mean, it matters, but then I don't want this to sound brand specific.
Right,
But
right.
yes, I am interested in the science. I want you to understand the science. Because you are using a surgical laser, it may be an 810, it may be a 940, it could be a 980. These are the three common surgical wavelengths in the diode options that we have in our country. So irrespective of which one you are using, I'll give you a simple setting for two things. One is what you do inside the canal. One is what you do outside the canal. What you do inside the canal is for endodontic disinfection. What you do outside the canal is for photobiomodulation at the periapex to ensure that the lesion that you're talking about heals uneventfully after you have taken care of the culprit. I always give this example to my students. When you are treating something, an endodontic lesion, you need to understand who's the culprit, who's the victim. The culprit is always inside the canals, the bacteria and the endotoxins. The victim is always at the periapex, the periapical tissues. So you need to approach them separately. You do if suppose you want to use a photothermal range, you don't need a dye for that. Please go take a 200 micron endodontic fiber on whichever machine you have, just bend it properly. Make sure that you set your laser at 1 watt, 1.0, 1 watt continuous wave. Take it down to your working length, reduce 1 mm from that, and then in concentric circles, you withdraw that fiber, spending about 15 to 20 seconds per canal. Please don't do this in a dry canal. Do this in presence of hypochlorite or hydrogen peroxide or your 17% EDTA, any of them.
Right.
Do that in a wet canal. That is what you do for the disinfection part. Repeat this 3 times. Okay. Once you are done, you have taken care of the culprit. 99.99% of the organisms would have been killed by this, even to the extent of 1000 microns laterally inside the dentinal tubules. So there is a very famous thing which I keep repeating. You will appreciate it. Where nothing goes, light goes, for sure. Yeah. That is what you do inside the canal. Now your work is not done. You've only taken care of the culprit. The victim is still sulking. What do you do for the victim? You change the setting, take the tip out, right? If you have a PBM tip given by your manufacturer, well and good. If you don't have, still okay. Take the surgical tip out, use the bare handpiece on the periapex, bring down your power level from 1.0 to 0.1. That is, from 1 watt, you are coming down to 100 milliwatt. I'll repeat that again. For the photothermal disinfection, you had used it at 1 watt continuous wave. You bring it down to 0.1 watt now and hold it at the periapex of the tooth that you have just obturated for 60 seconds. Repeat that 3 times. This will enhance the healing. This will give a good vasodilatory effect, and the lesion will heal uneventfully. I hope I've cleared that.
Very nice. Thank you so much. And another question is it helpful in psoriasis?
Psoriasis, the work is happening, but yes, we don't have enough evidence to say that this is how effective it is. Like I said, it will definitely be effective than the generic pharmaceuticals that are available to treat that. But to what extent, if I have to give you a percentage as to in psoriasis, it is this % effective, we still don't have those numbers.
And when we are talking about investigation, any investigation that you have started with COVID cases?
Sorry?
For COVID cases. Are you doing anything?
I am doing a lot of work for COVID. In fact, writing a lot of stuff. I can share that with this group. We published one recently, what lessons we have learned from the Spanish flu and what we did not. This is not the first pandemic that we are facing. We had a Spanish flu, which was 100 years ago. And there it was proven beyond doubt that light plays a role, and how it has to be harnessed to make sure that the patients heal uneventfully. What we can do, at what stage we can intervene to prevent the cytokine storm that COVID patients suffer from, what stage we need to intervene on the lungs to prevent fibrosis. Different protocols are available, and yes, a lot of work is happening.
So actually, we can expect that laser can help us out with this.
Absolutely, absolutely. The new device that I showed you from Slovakia,
Right.
that's a BioQuant LED device. It's not a expensive laser, and that is given as a home care device for all those patients who recover from COVID but are not still 100%. For them, that device is meant. It's a polarized LED, and you just have to put it in their nostrils 10 minutes in the morning, 10 minutes in the evening. Just do this for a week, and all their body physiologies and functions will be near normal in 8 to 10 days.
So is that device available here in India?
Through Novolace.
Okay. Thank you so much, Dr. Chandrashekar Yavagal. This was enlightening.
Thank you so much for having me here.
Hopeful also. The cases we think are just done, we are done with, we cannot do anything. Laser is I think, something that can rescue us from that.
Thank you so much. It was a pleasure being here.
It was an honor for us. Thank you, Dr. So that was Dr. Chandrashekar Yavagal. We all speak about lasers. Lasers in endo have been discussed in prior session, but today it was like, as he said, full gyan of laser we got. And when I asked him about endo, the way he explained it, I am sure every procedure will have different protocol and different methods and different wavelength guidelines. So this is just the tip of the iceberg that we have seen. Obviously, we cannot expect a lot in 1 hour, but thanks to Dr. Chandrashekar. He has shared a lot of things, and especially showing those cases. It was an enlightening experience for me. For all those people who have joined us, thanks a lot, guys. Thank you so much. And thank you for being here. Thank you for posting up your questions. Thank you for being so active. So we all spoke about Novolace laser therapy machine. So I guess this is your last chance. If you want to win, one lucky person will win Novolace dental therapy laser machine. If you want that, what you need to do is by midnight today, you have to send screenshots of denoting your active presentation in this. You had to take part in one of the cultural programs. You have to be member. You have to register yourself at DRDCA app. Eventi app on DRDCA. Also, you have to fill the feedback form. Also, guys, the article that he mentioned, many articles are there in Dental Reach monthly subscription. We have Dental Reach magazine every month. Every month, one edition is there. So you guys can check it out. October edition is already there. November speaker special edition is also there. One more edition is going to come, and you can send your entries. You have to contact us at drdca2020@gmail.com. Just mention the main heading as a dental article, so we can look into it. The scientific head, Dr. Nupur, is going to contact you. You can reach to her directly also. drdca2020@gmail.com. It is written in the comment section. This is the place where you have to send your screenshots by midnight today. And you never know, you could be the owner of Novolace dental therapy laser machine. Remember, it ends midnight today, and the winner will be announced tomorrow 4 p.m. So guys, today is the last day of scientific session. We are left with evening session. Monday session is done. We had Dr. Castillo with us. We had Dr. Yavagal with us. They spoke about fiber reinforced composites, a topic that has been spoken about. But yes, a very simple and informative session by Dr. Castillo. Then Dr. Yavagal, we just heard him, and it was amazing experience to have both of them on board with us. Thanks to DRDCA team. And now I'll see you guys in the evening at 4. We have Dr. Ranganatha Rao speaking about techniques of implant impression. We have Dr. Kevin who will be joining us from Philippines, and he's going to speak about digital branding. I think a must topic in today's time. So yes, you can see in the comment section link of feedback form also. Kindly send the feedback. We have worked very hard. You have been so patient. So just it won't take much time. Do drop us a feedback. And yes, your certificate of participation will be sent to you over the mail after within 2 weeks once the conference gets over. So after 2 weeks, you will get the certificate on your mail. So no that, but yes, do fill the feedback form. You can write a separate note for me, as I've been your a sweet host throughout the session. So on that note, I'll see you at 4 p.m. This is Dr. Pallavi. Okay, that I was just reading comments. So thank you so much. This is Dr. Pallavi Mahajan signing off from the morning session, and I'll be seeing you at the evening for the evening session at 4 p.m. Bye bye, guys. Take care.